Welcome back to the Future Health Podcast Series 3 for another look at the way we work, the work we do, and how the future of health will deliver care to our patients. This series, we have a special treat for you. It's a great pleasure for me to introduce you to a great colleague and friend, Sirisha Golakota, who is going to host our series this time. Sirisha is an experienced leader in New South Wales Health and has had a long and distinguished career in the health sector. She has been a part of big policy reforms and is personally passionate about social justice and equitable access for consumers to services. In particular, she is interested in progressing the role of women and leaders and the important role they play in building economic and socially responsible contributions to our society. I'm sure you'll enjoy this series with Sirisha, and I hope you enjoy the conversations as much as I always do. And I look forward to seeing you again in the future.
I don't like the fact that it was COVID-19 that drove us in this direction, but I do like the fact that we have embraced technology and utilized it more directly with patients on a day-to-day basis.
Welcome to Series 3 of the Future Health Podcast, a podcast on the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry. We have an incredible lineup of guests this series, and we look forward to sharing it with you soon. Feel free to like, share, and subscribe so you don't miss a thing. Hello everyone, welcome to Future Health Podcast. Our guest today is Dr. Fatima Cody Stanford. She's an obesity medicine physician scientist, educator and policymaker at Massachusetts General Hospital and Harvard Medical School. She has received numerous awards throughout her career, including the Gold Congressional Award and a number of other awards. Her primary expertise is obesity and nutrition. However, she's also published a lot of work on diversity and inclusion in healthcare, which is a very topical and interesting area that we're very keen to explore. So thank you so much for being here today, Fatima. I was hoping you could do a short intro about yourself and expand on what I've already said. It would be great for our audiences, and then we'll jump into some questions.
Absolutely. Well, first of all, it's a delight to be here and to be expressing, a lot about the work that I do. And I'm hoping that it really yields to great discussion and enhancement of the knowledge that people have surrounding, my topics, which are obesity, diversity, equity, and inclusion. So I am an obesity medicine physician scientist, as you stated. And so people are often perplexed by what that means. What is an obesity medicine physician scientist? I am a person that cares and treats patients that have the disease of obesity across the age spectrum. I completed residencies in internal medicine and pediatrics. So my patient population range from the age of 2 to the age of 90. So a really, I would say, broad spectrum with regards to age. In addition to that work, I'm one of the first fellowship trained obesity medicine physicians. So after completing those residencies in internal medicine and pediatrics, I came here to Mass General and to Harvard Medical School to do a 3-year fellowship in obesity medicine prior to coming on to the faculty here at Harvard Medical School. So that gives you a little bit about kind of my educational background and really a lot of that commitment to obesity. My work in diversity, equity, and inclusion really began over 25 years ago as I began to explore these issues in particularly the sciences and then with a particular focus in medicine. Here in the United States, I serve as the Director of Equity for the Massachusetts General Hospital Department of Medicine, particularly the endocrine division. I serve as the Director of Diversity for the Nutrition Obesity Research Center here at Harvard. And I also oversee our anti-racism initiatives here in the neuroendocrine unit here at Mass General Hospital. And finally, in addition to that, I serve as the director or the senior advisor for all diversity, equity, and inclusion efforts for the National Institutes of Health for the NORCs. And the NORCs, Sirisha, are the Nutrition Obesity Research Centers throughout the country. There are 12 throughout the United States.
Wow, that's incredible. Would you like to come over and work for us?
You know what? I am movable. I hope that my colleagues here are listening to that.
Yeah, absolutely. And look, I think it's really interesting that they're sort of, two different but related areas. So I'd like to dive into both of them, okay. One and then another, and then bring them together, because I think there's an interesting story there. So I think let's start with your first specialty, which is obesity and nutrition. And as I've said with a lot of these podcasts, is let's address the elephant in the room, which is COVID-19 pandemic, which has impacted everyone significantly, but for a good portion of the population regarding, working from home and being restricted and locked down, it's limited our mobility significantly, and particularly children, in terms of their ability to socialize and exercise. As best you can, what do you think the long-term effects of all of this will have on something like your area, which is obesity and nutrition, where we're already struggling in that area and with terms of health outcomes?
Yeah, no, absolutely. I think the story of us evaluating this pandemic of COVID-19 is really important in the context of what I see as a larger long-term pandemic of obesity. And actually, I recently gave a TED Talk on the collision of what I see as three pandemics, which is obesity, COVID-19, and then our issues with evaluating race and racism and how the interplay between the three of those communicates. So let's talk about COVID-19 and obesity. And I think, Sarisha, you brought up one key issue, which is relative immobility, lack of physical activity that has been more pervasive during the pandemic than prior to. But I think that shortchanges the story of really evaluating what's happened in the context of COVID and why we've seen major shifts in weight status, throughout the world. I think that the number one reason why we've seen that is really secondary to increased stress. And I think that regardless of our race, ethnicity, gender, sexual orientation, country of origin, that during this pandemic, we have seen a significant increase in stress. And what we have to know about obesity is that it is an inflammatory condition, a chronic inflammatory condition, which is such that when we experience stress, we typically store adipose, and adipose is fat. And that happens across the age spectrum. We see this in children, we see this in adults. And so this uncertainty surrounding the quote unquote end of this pandemic, which I think we can all agree has not yet ended, is what I think has led to some major shifts in behavior and also rates of obesity. So I think that the long-term impacts of this pandemic on our other pandemics, so the pandemic of COVID-19 on the pandemic of obesity, are really vast and unfortunate, because I think we'll see this pandemic of COVID-19 linger for much longer than any of us would like to acknowledge. And I think it will have some downstream impacts. And just like 2 weeks ago, here in the United States, the Centers for Disease Control and Prevention released our obesity maps that took us through evaluating what we've seen in terms of rise of obesity through 2020. And we've seen a significant shift here in the US, but we're seeing this around the world. So I hope that kind of delves into kind of what we're seeing with this overlay of looking at this acute inflammatory process of COVID-19 and this chronic inflammatory condition, which is associated with the disease of obesity.
Yeah, and I think it's an interesting point there you raise about stress, because obviously something like mental health has a significant impact on the way we behave and the way we move and everything, and being active and how important that is. I'd be interested to hear, in your experience and what you're dealing with, are there things that are working that you can, that you're thinking about now to address some of these long-term effects? Are there initiatives or strategies that, you're doing that we could possibly look to do as well? Because I know for a lot of what's been happening with the pandemic, because Australia has been a little bit further behind in terms of the impact, it's been, in many ways, we've taken advantage of the fact that we can learn from the rest of the world. So I'd love to hear if there's anything you're doing that you think is working.
Absolutely. Like if we're talking about obesity, which is, I think, where we are right now, one of the things that I have found to be something that's been successful during the pandemic in terms of the patient population I work with is the consistent need for intervention, and doing that via a telehealth model. So during the pandemic, obviously we were trying to keep as many people out of the hospital system because we needed beds, we needed space. And for these type of chronic issues, that we could do this type of visit interaction, via a telehealth model. So our center, the Mass General Hospital Weight Center, went to 100% telehealth during the pandemic, and I did not see any patients in person for over 14 months. Now, you might wonder about like what were the outcomes associated with me not being able to touch, feel the patient. Actually, what I found was that during the pandemic, my patients, about 90 to 95% of them actually lost weight during the pandemic. And I think it was that frequent, consistent interaction and treating their disease of obesity actively during the pandemic, which led to these really great outcomes, which really are divergent from what we're seeing, when we look at the population as a whole. So being able to use our technology to our advantage to engage and to uplift our patients that are struggling with chronic diseases like obesity has really borne out to be a really effective intervention. And we were doing this not only with people like myself, the obesity medicine physicians, but we were doing similar things with our dietitians, our psychologists, going back to that mental health piece, Syrisha, that you mentioned. And obviously, we did have a delay in, let's say, patients seeking metabolic and bariatric surgery, because what we did was we moved more acute issues ahead of those surgeries. But those other three professionals that I work with closely in the work that I do here, we were able to deliver this care in a remote fashion, and patients were able to get the care they needed, see their health improve despite us being in what we would never have guessed, one of the most potent, if not the most memorable pandemics of our lifetime.
Yeah, and it's interesting because my next question then was about technology and interventions that have worked. And, as a result of the pandemic, we've had to accelerate implementation of things that we may have done differently in the past when it comes to healthcare. So did you find your patients, embrace the telehealth, and were there other technological, interventions that you used and that were effective that you would, I guess, and how would you continue to use them?
Absolutely. I think these are excellent questions with regards to technology and how we can utilize it in a positive way. We usually think of the negative outcomes of technology, screen time, et cetera. So I will just give you a little bit of a nuance in that prior to the pandemic, I had already been seeing about a third of my patients via telehealth. So several of my patients were acclimated to this idea of not necessarily being in the space with me. Were patients, particularly many of my older patients, that prefer to be in the physical setting, may have had more technological challenges trying to get online and conduct themselves in a visit, maybe never having even something like a laptop to do this type of work. And so I found that patients that were either older or had lower resources, meaning economic resources, found it to be a bit more challenging to get on. When we went 100% to telemedicine, I felt really that it was very easy for me to do it because I had been doing it, for, a third of my patients for several years prior to the pandemic start. But many of my colleagues, were not acclimated to it. So there were, in terms of our entire hospital, let's say about 10 to 15% of the physicians were doing telemedicine pre-pandemic. That went steeply to over 85% of physicians doing telehealth during the pandemic. So there was a major shift, but I felt, like I had been onboarded prior to the pandemic and felt comfortable. I can still tell you that a predominant engagement with regards to my practice is still via the telemedicine model. Patients became so acclimated to it, loving not having to drive for several hours, find parking, these types of things to come into the office. And all they have to do is sign on 5 minutes before their visit with me, get what they need, and then go about their day. I have found that most of my patients, I would say about 85%, still prefer that as the modality by which we communicate. So much so that with regards to an actual month, I'm still seeing only about 20% of my patients now in person. So that still shows you that, we're predominantly, so I went from a third telehealth visits to about 80% currently as we have shifted into this kind of post-vaccine pandemic, but it's still obviously very much here. Other things that we've tried to utilize in terms of technological advances include things like digital scales to transmit data back into our electronic health records. We've also tried to pilot that with using blood pressure cuffs and things of that sort. I have found those to be a bit more fickle. There's not a lot of consistency with the technology and being able to get that information over to us. So I am typically asking the patient, what is your weight today? Can you give me, certain key details? Waist circumference is the second question I always ask about, which I really like because it's not something that requires anything fancy. It just requires a basic tape measure, and I tell them where they need to have been measuring. And so, I do think telehealth is here to stay. I think that patients have learned to embrace it and love the fact that they are not having to block out half of their day or a full day to get to the doctor's office for things that are more chronic and routine in nature. And so I think that will remain a major part of medicine. Medicine has been known to be slow to adapt to technology, but we were forced to do this. And so our hospital rollout of onboarding physicians was supposed to be a 3 to 5 year plan. And they had to change that to a 3-week plan with the pandemic. And so I don't like the fact that it was COVID-19 that drove us in this direction, but I do like the fact that we have embraced technology and utilized it more directly with patients on a day-to-day basis.
That was really interesting, Fatima. And I was particularly interested in what you pointed out there about, how some technologies just don't work or they don't cut it because they're not ready yet. And, we have this massive focus on precision medicine and, monitoring apps. Like it's been talked about a lot when it comes to the future of work and technology. So I was I love that anecdote about how a tape measure is just as effective as, any. So I was going to delve into that a little bit more in terms of simple interventions. Okay. What were the things you did for the people that weren't necessarily able to embrace the technology? So we talk about diversity and inclusion when it comes to the workforce, but our patient cohort is very diverse and we need to include people and make sure, care is equitable. So for the people that say struggled with the telehealth or other, what did you do to ensure that they were still getting the care that they needed?
No, I think that's a great question. So there are a few things that I did to really make sure that I was getting to my patient population, which does tend to be more diverse in terms of race and ethnicity and with regards to socioeconomic status. So I'll kind of go over those two things that I did to accommodate them. Here in the United States, we were allowed to do just telephone calls for those that were older individuals. So what is Medicare insured patients here in the United States, that would be usually the population of 65 plus here in the United States. We were also able to use that for our Medicaid population, which is for those that come from lower socioeconomic status. So a simple phone call might suffice. Now, I'm not able to get the same real live data where patients are showing me what's in their refrigerators and their new weights, for their workout, for example. But I'm able to still have a conversation with them about what's going on, if they're on medications, if they've undergone surgery, or, even about their nutritional status, sleep status, et cetera. So that was one that's obviously an old school technology, the telephone, right? I could use that. For those that were willing and able, there is a company here called Doximity that had it such that you could call out to the patient, basically send them a text message. And instead of them having to log on to our system, which can create some angst for patients, all they had to do was click the link in the text message that I would send them and I would appear on their screen. And they'd be like, oh, there you are, Dr. Stanford. So I appreciated that company took some additional steps to make it easy instead of them having to log on, wait for me, get another chime into a room and understand technology, that they would just be able to, if they had a smartphone, which most of us do in the US, they could just click on a link and see me appear on the screen, and we could embrace a video visit in that way. So those were the two interventions, the telephone and using this technology from this company that is geared towards physicians, so that I could just call them out from the office, basically from the office number, and they click a text message and see me on the screen, which they'd be like, wow, look, and they feel like they did something really exciting, but it's me doing the work, which is fine. I just want them to be able to do their visit.
Yeah, and that's amazing because it's so simple for the patient. You click a link, and someone else is doing.
Yeah,
the work.
they're like, I don't see it. I don't see it, Dr. Stanford. I'm like, yes, you do. It's the text message. I know it's there. Oh yeah, I see it. And so then they click it, and then I'm on the screen.
Yeah, are those the sort of things that, in addition to the telehealth, that you're keeping in terms of?
Oh, absolutely.
Yeah.
Oh, hands down
Yeah.
there. And also, I will do that to find my patients. Let's say I see that they're not signed on to the system, and I know that we have a finite period of time to complete this visit before the next visit with the next patient starts. I will utilize that technology to contact the patient in case they're having any technological difficulty signing onto our formal system at our hospital. And I make it such that I would say that reduces, any potential no-shows or them being flustered for their technology not quite aligning with our completing the visit. And so I've continued to utilize this even to date.
Oh, that's amazing. Yeah, because I think that's some of the things we struggle with here, which is no-shows and people, feeling intimidated to show up for whatever reasons or,
Right.
because it's too hard. And so that's something so simple that could be utilized so effectively. Do other colleagues use a similar technology as well? They do, yeah.
Yeah, absolutely. So that Doximity technology is nationwide, and it's a free service to physicians. So, and I think it may be for advanced practice providers also. So those that are nurse practitioners or physician's assistants might have access. I think have access to that technology also. And so it's like one of those things that, like, how do you make the clinician's life easier? Give them a technology where they can reach their patient. And like I said, very rarely am I reaching patients and not having them have the ability to get on. There are a few patients that still have flip phones and things of that sort, and it'll kind of push back and say, their technology is not such that they can do a visit, but that's a rare find.
Yeah, and it's interesting there too, because you've got, the ability to call them, you've got this technology, right. And then you've got the system right. as well, and it's almost like you've got backup for backup for backup. Yeah, it's amazing. I think exactly. that's a really interesting, simple but effective intervention, and that's definitely something I think we should look into. It's incredible. I want to take us down a slightly different route now. Okay. We've talked about obesity and nutrition, so I was interested to, given we've talked about diversity and inclusion with patients, maybe talk a little bit about your other area of passion and talk about diversity and inclusion of workforce. This is a Future of Work podcast, and if we have a diverse patient population to meet their needs, should we have a diverse workforce as well?
So this is one of my passion areas, and this has been the focus of most of my day today. So I'm very passionate about this work of looking at the, diversity in the workforce. And so if we want to focus on, for example, physicians, I'll use the US data to kind of inform what we're seeing. For those of you that aren't looking at me, I'm a Black woman physician scientist here in the US. And what we do know in terms of the number of Black physicians in the United States is that it has only changed by 4% in the last 120 years. So there's only been a 4% increase in the number of Black doctors in the United States in 120 years. That was a big paper that came out earlier this year from one of, not my colleagues here in Massachusetts, but a colleague out in California. And I thought that was really important because what we do know and what our studies have shown, and including a recent study that I published in the Annals of Internal Medicine, going back to that topic of COVID, for example, and messaging to patients that are Black and or Hispanic here in the United States, is we found that for our Black patients, like me as a Black physician, they prefer to receive messaging and care from physicians that look like them. The problem is that the number of physicians that are Black in the United States ranges, depending upon what study you're looking at, between 4 to 5%, whereas our population is closer to 14%, which means that there is a paucity of physicians that are suited to treat the patient population that needs care. Some of this comes from a history of distrust of majority communities and issues that have happened throughout history that have made it such that people have distrust of providers that don't look like them. But one of the issues that we've seen is that, particularly here in the US, but I think that this is commonplace throughout the world, is that as we continue to climb that educational ladder to physician and do all of the training necessary to be able to deliver care, that there's a select group, often a group that's of higher socioeconomic status, which has tools, resources, and generational wealth that allow someone to be able to get to that level, to be able to serve in the role that I serve as a physician. And that's unfortunate because, like I said, if you're looking at what people want, where they would seek care and get care on a regular basis, they're looking for people that they feel like identify with their plight in life. And I feel like this is something that is germane throughout the world in terms of having people that people can trust and identify with to receive their care from.
Yeah, and it's an interesting, because we have similar issues here when it comes to our Indigenous population with our Aboriginal and Torres Strait Islander people. There is definitely an element of distrust because of historical atrocities that have happened to the people. Of course, and I'd be interested to hear, I'm going to be a bit controversial here. You get the naysayers well, I think, you might appreciate this and might have similar experience. You get the naysayers who say, well, everyone should be treated equally and it shouldn't matter who provides you care, whether they're black or white or Asian or, Indian or whatever it is. What does it matter? They're getting the care that they need. And obviously you probably have come across that. I think you're nodding there.
Oh, yeah. I'm ready for you.
How do we address some of those biases, basically, and those assumptions that are incorrect?
Yeah, actually, it's interesting. I'm not surprised to hear that as one of the things that people experience. And often I think that comes from a lack of knowledge of what it's like to live, eat, and breathe, for example, as an Indigenous person in your country, as a Black or Indigenous person here in the United States. And what we do know, and I can tell you, I'm going to reverse myself from taking myself out of the role of the physician into the role of what it's like to be a patient. When I'm a patient, and people don't know that, I have, 5 degrees and did all this stuff, I'm just viewed as a Black woman sitting in a gown in a hospital or in a doctor's office. And with that comes assumptions about what my knowledge base, my value, my worth is as an individual. And so the treatment that I receive when the tables are turned, when I'm in the seat of the patient, often reflect what my patients are concerned about. I feel treated that, not heard, maybe in terms of my concerns. I feel as though, what I'm delivering to a physician, if they are unaware of my background, is not taken into account in terms of what my own internal thoughts are about whatever condition I might have. And so that's coming from someone that has the level of education and knowledge that I can convey, right, to a physician or other provider. Imagine what that's like for someone that doesn't have that capacity. That's even more of a barrier. So it's a barrier for me, but you can add several additional layers to that for those that have limited education or health proficiency, which I think is a major issue. When I'm talking with my patients across racial, ethnic bounds, but particularly if I want to focus on, let's say, my Black patients, I try to identify with what is their concern, what brings them here, what will make them feel comfortable, but recognizing their lived experience probably came with significantly more challenges than those that were from majority groups. And that knowledge gives me an ability to identify and embrace their experience, what they're communicating to me, because they know and live in their body all day. I can give my expertise, but they are able to inform me about what's going on with them. And then I'm able to help them be their best self. So, for those that believe that this cannot be an issue, I challenge you to take the Harvard Implicit Association test. It's a free test that you can take, and you can take one for race. And it's a quick test that's been validated to determine if you do indeed have biases towards certain groups. You could have biases toward those that are white or those that are Black, for example, and it will really accurately give you that information. I think that's a place to start to inform whether or not you have biases. And if you recognize that you do, because most will have biases one direction or another, recognizing those and beginning to work to make progress and change.
Yeah, and I think that's a powerful thing there, because like you said, we all have biases. We bring them with us every day. That's just being human. It's how do you put that aside to look at the individual and not at a bias. And if delving into that a little bit more, because you're a physician and you treat patients, there is an element, and, as you were talking, I was thinking about, as a woman being in a doctor's office and being told well, that's a woman's problem. We heard of, endometriosis being ignored for years by male doctors it's just period pain, for example. There is an element of, there are certain things that inherently come with your ethnicity. So, for example, certain comorbidities that you might be prone to, but then you also are an individual as a patient. As a physician, how do you balance those two? Because when you say, look at someone, say your patient is Black, they're Black, so they come with certain ethnic, if you will, inherited but at the same time, they might not fit that norm. How do you balance the two to be able to have an open conversation about their health outcomes?
Yeah, no, I think that's another great question, Syrisha. I think what I do is I really do a deep dive at their initial visit. So my initial visit with each patient is at 1 hour in duration, which is a lot of time. So I'm delving into all of their life history. It's probably the most extensive physician visit they've ever done in their life. And I tell them that at the outset, this is going to feel like I'm covering every, nook and cranny of your life. But the reason why I'm doing that is to better inform how do I directly approach them about things that may have a higher prevalence within their individual cohort. But I have to listen to all of the nuances. So let's say someone says to me, okay, we go through everything, but then they say, I'm not sure of my family history because I was adopted, for example. I won't have that knowledge to inform what their risk factors are for obesity or heart disease or diabetes, and the list goes on. But if I talk to a patient and they tell me, for example, that every single person on both sides of their family has a history of obesity, and, 90% of the men in their family have had heart attacks by the age of 45 and all these types of things, I'm getting some really key points about how I need to inform my conversation in terms of interventions to better guide outcomes. So, for example, there's a woman who I just saw last week who's a nurse here at our hospital. And she's in her mid 50s. Actually, she is slightly later 50s, 57 years old. And she has now outlived every woman in her family, meaning she's lived to be older than every single woman in her family. A lot of it was this early risk of heart disease and things. And so we had some aggressive interventions. I did send her to bariatric surgery about 4 or 5 years ago. Her metabolic health is improved. She has no evidence of high cholesterol. She has no evidence of all of the diseases that were what killed her family. And so she said to me, and this was obviously an emotional visit to me. She said, Dr. Stanford, thank you for giving me life. I've outlived all of my family members, and I really think that was because we aggressively treated my obesity and obesity-associated diseases, and she's thriving. That's the type of interaction I was able to inform because I got that information at her initial visit so I could guide her to the best treatment strategies in light of that history. So I use, and we talked about that precision or personalized medicine. I use that information to then guide me to give the best possible recommendations based upon that.
Yeah. And I mean, and again, interesting because we talk about, diversity of workforce. And if you need the right person to be able to probe and ask the right questions there. And that's why something like having a diverse workforce is so important, because not everyone is going to understand every patient. How important do you think that is in terms of, at the risk of making it simplistic, you being a Black woman, treating someone Black and understanding what history to some extent comes with that person from your own personal experience?
I actually have many circumstances or situations where Black women, for example, since this was the group that you pointed out and the group that I belong to, will wait for months and months and months for me to be their doctor because they feel like I will identify and hear them in a way that they have not been heard previously. And this is for women across the spectrum, from young women, since I told you to take care of a large age spectrum, to women who, could be my grandmother, right? I'm in my 40s, but so these are much older, women. And they, for the older women, they see me as like they're kind of like child or, grandchild, but acknowledge my expertise in the area and are very receptive to what I say. They'll say, Doc, if you say that, I will trust it. And I don't know if they're having those same conversations with those that they don't identify as much with. And so I feel like I'm able to make strides such that sometimes their primary care physicians might reach out to me if they feel like I have a strong connection about, let's say, another issue that may or may not be directly related to their obesity. And they're like, well, I know you have a great relationship. They talk about you with in their visits. Do you mind bringing X, Y, or Z up? And I might bring that same issue up to the same patient that just turned down this exact thing from their primary care a day before. And then they're like, oh, okay, well, Dr. Stanford, you say that, I'll do that. So it goes a long way in terms of, what are patients willing to consider? Do they feel as though you are malignant in your recommendations based upon any potential issues that they have had personally or in their family in the healthcare setting? And so I think it goes a long way.
Yeah, and it's I think you've hit the nail on the head there when you use the word trust. It comes to, what does a patient trust? And patients come with their own bias too, understandably. But I guess from a health workforce point of view, it's our job, rather than bringing our biases, to try and break down some of those barriers. So, we probably don't have too much time left, but I'd like to ask you at least this question. What can we do as an organisation, or say, I'll use New South Wales Health as an example, to attract people of different diverse backgrounds in order to then be able to provide the best care to our diverse patient populations? And maybe you can speak from your experience, like, in terms of what attracted you, and what would you say would attract other Black people, Black women in particular, who are definitely less visible in terms of those positions. Yeah.
So I think I hope I won't make this answer too long, because I have a lot of thoughts in terms of this question, in terms of,
no, please do,
what can be done. Right. But I'll try to be concise, but also, provide some context. I think you can't be what you can't see. And what I mean by that is that we need to have people that are examples and role models. We've seen this play out in cartoons and things here. For example, there's a Doc McStuffins cartoon where there's a young Black girl who is a physician for her stuffed animals. But she is, in this cartoon, her mom is actually a physician in real life. It's a cartoon, so real life in the cartoon. But she sees that, okay, well, this is what mom does. This is what I'm going to do with my animals. And, that's influenced quite a few young girls to begin to think about it. It's a cartoon, but it's still visible, right? You can't be what you can't see. So I think that role models, and some of these role models may be not necessarily tangible. They may be people that they see from a distance. It may be in a cartoon, but these are things that make it seem possible, right? If you see it, then you can potentially be it. But then that goes to the next issue, which is this idea of pipeline, which means that recognizing that when we're looking at physicians or other healthcare providers, this education starts very early in life. For me, I knew that I wanted to be a physician from the age of 3. I'm in my 40s now, so quite a few years ago when I decided that this was the path I wanted to go down. I grew up in Atlanta, Georgia, here in the United States, and in my zip code, there are more Black doctors per capita than anywhere in the United States. So I could see it, which meant I could be it. I know that many of my colleagues here in the US and around the world don't quite have that degree of role models by which they can see so that they can believe that this is possible. I had resources along the way, really quality education that allowed me to be able to continue down this really long and arduous path to medicine. And I think that once you're here, it's important for us to recognize that how do we retain individuals? Many times in our environments, and I experience this unfortunately regularly, the environment can be very hostile to persons that are from indigenous groups or persons of color. And this is what then, they've done all this work, they've gotten here, they've kind of made it, so to speak, but then they don't feel like they're welcome to remain in that environment. So there's so many different places along this trajectory, starting from early exposure to the pipeline, to, being encouraged about, making it down the pathway, and then retention. And so there's a lot of areas where there can be fall off. And even for persons like myself that have quote unquote made it, accomplished things on Harvard faculty, I still face these challenges. And the reason why I continue to push is because I know that there are those that are coming behind me. I need them to see me, and I hope that they have an experience that is much easier than the experience that I've had in this pathway, and continue, like I said, to experience today.
Do you ever feel, you don't have to answer this question, but do you ever feel the pressure of being the kind of torchbearer? Because I think that's something we hear from, certain senior Aboriginal and Torres Strait Islander clinicians. Like, there is an enormous pressure to be that one from your community who's made it. You've come from disadvantage and you finally made it, and suddenly you have to live up to these expectations. Do you feel that sometimes? And do you think, wow?
I don't really feel pressure in that way. I see myself as a trailblazer. I think I've always seen myself that way. So I'm fine to carry that torch. Where my frustration comes is that when you are that torchbearer, being under significant greater scrutiny because you are the torchbearer. So being held to a standard that is almost inhumane. When I look at, myself and my accomplishments, and people are like, my gosh, you have 5 degrees and you did 2 residencies and 2 fellowships, and your CV is over 140 pages. And all those are great, but that makes it such that I'm scrutinized even further. It means that I have to even jump 10 times higher to just be at the same level as someone that may be from a majority group. And that's the frustrating part. I don't mind blazing the trail. I'm all about blazing the trail. And I don't feel per se that pressure. But when I'm faced with greater scrutiny, more challenges just because I am who I am, that creates significant frustration for me. That is maybe different from what I'm hearing you say in terms of like carrying the torch. I don't mind. I like to be first out. I was a sprinter. I like to be first. I like to win. But that comes at an expense. When I received my Gold Congressional Award here in the United States, it was given to me by my Congressman John Lewis, who was one of the big civil rights activists during the Martin Luther King era in the 60s, but continued his work in Congress before his passing in 2020. And one of the comments that he made to me when I received that award back in 2001 was, Fatima, never stop fighting injustice. And so I made a promise to him then. He's no longer with us, but I felt like if he can go to jail and prison to make it such that I can just be Black and live and sit on the same bus and and not have to pick a certain seat because of the color of my skin, that I can do this work. Is it tiresome at times? Yes. Am I angry? Often. Absolutely. Is it the work I'm supposed to do? Definitely.
Fatima, I guess going back to your point about keeping patients at the center of care, and it's about humans and humanistic care. But we also talk about new technology and, how to use technology. How do we use technology safely and still continue to make it about individuals and patient care without technology bringing in biases into that?
Yeah, that's a hard question. Let me see if I can answer how we can leverage technology divest that technology of biases and provide humanistic care. Let me think about a few things. I want to bring up one thing. I think that all of us are familiar with Google, a search engine that many of us use. In 2016, if you performed a Google search for young Black boys, it returned only mugshots of young Black men in their teens. If you did the same search for young white boys and girls, usually you were met with smiling faces, maybe them holding football, American football, or soccer ball, or basketball, kind of these very positive images. When the story ran in 2016 in the Washington Post here in the United States, Google changed their algorithm such that when you did the same search, it no longer included that. So when we're designing technologies, artificial intelligence, which will become more and more germane as we continue to move in medicine, we need to have the right players at the table. The problem is when this technology is being developed and deployed, often there are not people like me in the room that are part of this discussion and exploration or testing to see that this does not create further biases, which we know are entrenched within our society. So the importance of that workforce comes not only at the point of care, me directly with that patient, but in the development of all things in medicine. We need to have a voice at the table, not because, we just want to be there, because our voice is meaningful in making sure that we don't further exacerbate the disparities that we see in healthcare around the world.
Yeah, I think that's a good point, because a lot of times it becomes a tick box exercise. It's like, we must include that person, and we've met our diversity quota in this consultation versus actually listening to someone. Yeah, it's a really good point.
So I have a wonderful thing that I'd like to add. I have a piece that's going to be coming out soon in the Lancet about being a Black woman in medicine. The Lancet is, of course, one of the prominent medical journals, and I capture quite a bit of this work that we've talked about, but particularly on the side of what it's like to be a Black woman in medicine, even one that has supposedly accomplished a lot of different things. And I think that I capture it in a very concise way. I pull upon others' experiences to support what I'm saying. I do talk about in this article of it being me being too much, but not enough. And that this is a consistent theme. And by that, I mean too much. You've done too many things. It's too much. But then, I don't know, are you really qualified for that? Even though you've done all those things, this is the consistent theme in this back and forth of like, are you enough, or are you not really enough?
I would love to read that. I think that would be, and I'm thinking about it as a woman, because, we talk about men will go for jobs that they're not qualified for, and women will be overqualified and feel like they can't do a job. And there's definitely.
So that's not the issue, I feel like, with Black women in the U.S., particularly Black women physicians. I feel like we feel like we can do the job. We apply for the job, but we're just not ever considered for the job.
Yeah.
At least that's what I feel. I don't know.
Yeah.
I can't speak on behalf of all Black women, but that's usually my situation. Like, I can do that job in my sleep, but I'm not given that opportunity to do that. And then this idea of Black women being a bit too outspoken and not yielding enough. So like too much, but not enough here again.
Yeah. Definitely not too much. I'll say that. I really enjoyed this. I definitely appreciated your honesty. I think it was amazing. And you've obviously got so much experience, but I love that everything you're doing is about your patients. Like, I think that's what really came across in this was, despite your 5 degrees and your medals, I think it's incredible. And, and that's why I think you have the medals, is because it's not really about, your qualifications. It's about what you do. And I think that's incredible. So thank you so much. I don't know what time it is for you over there.
I think my patients, they know that they're my family. If any of them happen to listen to this, I treat all of my patients, regardless of race, ethnicity, gender, socioeconomic status, like they're my family. And that's probably why they never leave me. I am treating, their chronic disease of obesity, but I treat them exactly how I would want to be treated if I were in their position. And there are often times when I wish that I had me. And in terms of the type of care that I receive, there are certain physicians of mine that I think do a good job, and others that could learn a few lessons from just what that lived experience, even via telemedicine, is with my patients who decide to take me on tours of their house so I can see the new renovations or what things they bought from the grocery store without me really even asking these things. It's because they see me as part of their family, and I see them as part of my family. And what would I want if I was in their seat? I would want the best level of care, regardless of who I am, regardless of my quote unquote VIP status, which I think needs to be eliminated in medicine, that they matter. And what they say is important. And I always tell them, look, you're the most important person in the room. I'm the doctor, but you're the patient. I have to hear what you're saying. You have to inform what I say to you. I can't do this without you.
Yeah, that's incredible and so true. I think that's thank you so much for what you do on behalf of, well, I'm a patient in some way. You're not my doctor, unfortunately. I would love for you to be my doctor, but thank you on behalf of all patients. And thank you so much for being part of this. I think it's just incredible. I can't wait till this is published. It's going to be amazing. And please do send us a link to the article you've written. I think we'd be really
when it comes out, it's in this last proofing stage, but I think it should be relatively soon. And it is, even when I read it, it can be triggering or emotionally triggering. So I just want you guys to have your Kleenex boxes ready.
It sounds incredible. I'm so looking forward to reading it. Thank you so much for everything. It's been
Absolutely
amazing. Is there any final thoughts or words you'd like to add before we wrap up? Anything you want to say or to our audience?
Yeah, so I guess I have a few messages for patients that are living with obesity. Recognize this is a disease. This is not your fault. There are people like myself that are trained to help you be your best self. It's not about a number on the scale. It's about getting you to your happiest, healthiest self, is what I tell my patients. For those of you who are racial and ethnic minorities who struggled and think that once you make it to a certain level that it won't continue to occur, you are indeed in for a rude awakening, but you can be part of the solution. And for all others, my allies, I need my allies from majority groups to help speak up with regards to these issues, particularly with regards to racial and ethnic minorities and disparities in care that we see across the world. We need allies. We need people that don't look like me, that aren't Black women, that are white men, that are white women, etc., to help elevate the messaging, because I can't undo what's been done to me. I need help. And so for those that are listening, please be a part of the solution. And that's all I have to say.
Amazing. Thank you so much. It's been fantastic. So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you're on right now.